I will call Professor Rajkumar from Dindigul Medical College. Well done.
Good afternoon and good evening to all of you. And the previous two presentations from Pudukkottai and Tirunelveli, they presented positive examples, but I am going to present a negative example. And number two, there was a detailed presentation from Tirunelveli, and my presentation will be very short. I hope you will appreciate, all of you appreciate me. Next slide, please. So this is the census in our college 2024. Total cases 718, out of which 3 patients expired. One from hemotoxicity, another one from neurotoxicity, the third one from acute renal failure, AKI. Next slide. This year census from January to March, total cases admitted were 135, one case expired, neurotoxic snakebite, and I am going to present this case only. All of these cases were managed in our medical college without a nephrologist. So this is a snakebite case study from our college. Next. 14-year-old female admitted at the time of 8:45 a.m. Time of bite was 4:30. There was a delay of 4 hours before reaching the hospital. And she presented with breathlessness and partial ptosis. Next. A neurotoxic snakebite diagnosis was made. Emergency management was given using anti-snake venom. 20 vials administered, 10 vials 1 hour at 1 hour interval. There was no adverse reactions to anti-snake venom. And the supportive measures were also given, neostigmine preceded by atropine, and she was intubated because of worsening neurological status. Next. And the clinical course of the patient, on day 1 there was some improvement with the ASV and neostigmine, atropine, etc. But on day 3 suddenly she deteriorated and succumbed to refractory hypoxia despite timely intervention and protocol adherence. So we do not know why the patient suddenly deteriorated and expired on day 3. So these could be the possibilities. Next slide. So some antivenom may not work against some of the snakes. The previous one. Previous slide. So there may be some geographical variation in venom and antivenom properties. Next slide. And toxin kinetics. There may be some possibility of delayed release of the toxins. Some patients may develop a delayed or occult coagulopathy or neurotoxicity. And in this patient, only one possibility, the patient came 4 hours after bite. That was the only thing we made. But in spite of that, we followed the conventional treatment protocol. And as I promised earlier, I conclude my presentation.
Thank you. Can this be due to some endotracheal tube block? Common things are commoner.
Yes, sir. But patient was treated in IMCU, but there was no signs suggestive of any tube-related problems, sir.
Right. Because the patient who was on intubation and mechanical ventilator support and they adequately given ASV, why she should deteriorate and die?
Still possible, sir.
Possible.
Sir, can you just tell me whether patient came directly to your hospital or did he go to any primary care somewhere? How was a patient presented to your hospital?
Patient was not taken to any private hospital or any other peripheral hospitals. They did not apply any traditional methods.
So they came directly from home to your
Yes,
hospital?
sir.
Because that is one of the problem in crate, they bite painless in the night, so we may not even know the time of bite. Morning only they recognize they got some weakness, something like that. So you're talking about the delay in arrival, not only
Yes,
in
sir.
arrival, because recognition itself may
Yes,
be...
sir. The time of bite was at around 4:30 a.m. and she went to sleep. And probably there might be a delayed recognition of the symptoms.
No, she knows that it was bitten and she went to sleep.
No, sir.
She's not aware.
Yes, sir. Early morning snake bite is
that
almost
is what,
always.
but
bleeding manifestations plus with neurotoxic features. Initially, I exactly remember one particular case where the lady went for plucking some flowers. She was not aware that she was bitten by a snake. She thought it was a thorn prick. She was brought to the hospital around 4 hours later, around 11 o'clock. While she was brought, she was having some dizziness. That was the initial complaint. But there was ptosis. When we were examining, we found that there was some bleeding from the gums. She had both features of both chemotoxic as well as neurotoxic. Later on, we found that it was a case of crite. It is present, certain particular type of snake variety is present in that locality where it is presenting with such features. And our ASV is not effective. Thank you.
So, but one thing that is on both the cases, Tirunelveli here, why the acetylcholine is given when after intubation, sir? Is it only adjuvant therapy? It is not a therapy to improve, or does not improve the outcome also. I think acetylcholine can be used as a tool. Suppose in case we are not able to intubate the patient to prolong, sometimes take some time for you to go. That time you can give an acetylcholine. Otherwise, once intubated, giving an acetylcholine, sometimes the patient, there is a mistake that every dose of Neostigmine was administered along with one dose of atropine was given. That is not the correct. I mean, this is only for discussion, sir, not for this one. That is also not the right way of giving the Neostigmine with atropine. I know. It's a whole fuss. It is not for a particular one. So there is no need for a neostigmine to be administered after intubating the patient, because the
too, especially when you are suspecting and treating it as a crate.
Crate, yes. And another thing here, sir, there is no other complication. The myocarditis and other possible complications should also be kept in mind. We always think that only the respiratory paralysis is the only cause for that. Sometimes the myocarditis, we have seen a lot of myocarditis suddenly going for a pulmonary edema and going for an arrest. So these sort of echo, cardiac evaluation also sometimes throw lights on what type of possibilities. So these have to think in your mind, not only respiratory cause, the myocarditis is also very, very important forerunner for a sudden death in snakebite patients.
Yes,
So
sir.
the lesson is we have to be very careful when you give neostigmine and atropine.
Yes, sir.
Any patient where it is indicated also. When you have the patient on intubation done, there is no necessity, number one. Number two, it could have caused excessive cholinergic crisis and excessive pulmonary congestion, a non-cardiogenic pulmonary edema, and blocked the tube. That's where I raised this doubt. Right, sir?
Yes,
Thank
sir.
you.
Thank you, sir.
Thank you, sir. It was an interesting, short and sweet discussion, as you promised. So, all three colleges, I think they have presented very well, and the take-home would be, we would start with 10 vials ASV stat, and if your WBCT is more than 20 minutes, do it again repeat again after 6 hours, because when I went to Chengalpet Medical College, I did notice that PGs were giving, one WBCT was more than 20, and then they were giving 30 vials at a stretch. I was very surprised. I was asking them why at a stretch at emergency medicine.
Not more than 10 vials at a time. So then let that be the carry home message.
So I think with this, I think we thank the NHM for this wonderful opportunity of bringing all of us together, and thank you, Lydia, especially for that. And
Thank you, madam. Thank all
thank
the
you, CR sir,
participants,
and all three.
panelists, and the
We end this
professors.
session
Thank you.
and we'll move on to the next session.
Thank you, ma'am. Thank you.